now I would like to start our ceremony. Today we are very proud and happy that the University of Health Sciences, in collaboration with Institut Pasteur in Cambodia, organized the scientific seminar entitled Success and Limit in Epidemiology. I would like to announce that among the audience, we have a lot of US students from national and international programs. Most of them are from Faculty of Pharmacy and Faculty of Medicine. Moreover, we have the presence of mass open online course students who have successfully finished their work during the first batch of the training. And besides, we have a lot of honor guests who from the partner of the UHS and Ministry of Health. So now I would like to invite the honorable guests, and when you hear your name, please come to the stage. First of all, I would like to invite Excellency Professor Min Chi-Woon, advisor to the Ministry of Health. Professor Arnaud FONTANET, the speaker, please. Professor Didier Fontenille, Director de l'Institut Pasteur. Dr. Olivier Sénégal, ANRS, And finally, I would like to invite Professor Seng Sopir, the UHS Director. I would like to announce the agenda of the seminar. First, welcome remarks of Professor Seng Sopir. Second, introduction of speaker and workshop presentation. Then we have Q&A session. After that, we have mock certificate or achievement presentation ceremony. And after that, we have the friendly picture outside the room. So now I would like to invite Professor Seng Sopir, Director of the UHS, to deliver his welcome remark. Please welcome him with a big round of applause.
Thank you, Professor Didier Fontenille. First of all, I apologize to give the remark in English because the seminar was set to be provided in English language. In so on, nowការចាប់អារម្មណ៍នៅក្នុងពិធីបើកនេះជាភាសាអង់គ្លេសភាសាការកំណត់ភាសាការប្រាស្រ័យក្នុង seminar គឺប្រើប្រាស់ភាសាអង់គ្លេស First, I would like to pay my respect to His Excellency Dr. Min Chi-Woon, advisor to the Ministry of Health in charge of the affair of the University of Health Sciences and Research activities. Dr. Didier Fontenille, Director of Pasteur Institute in Cambodia. Professor Arnaud FONTANET, Professor from the Collège de France. Dear colleagues from other departments and centers from the Ministry of Health and UHS partners. Dear management team, lecturer and staff of UHS, and especially welcome all our UHS students to this seminar. On behalf of His Excellency, the Rector of the University, I would like to extend our warm welcome to you all at this seminar on success and limit in epidemiology. Today, we are very pleased to organize this seminar, combined with a ceremony of certificate presentation for successful students or participants who have completed the OOC course on concept and method in epidemiology, with the support from the partnership between the University Institute in Cambodia, ANRS, the French Embassy, and the Japa Foundation. I would like to also thank our guest speaker of today's seminar, Professor Arnaud FONTANET, a renowned epidemiologist from the Collège de France, for delivering the lecture on this interesting and useful topic in epidemiology. As you may know, epidemiology is a discipline that has many merits and applications for health sciences and public health. Many research activities apply the epidemiological concept. I just would like to mention some. You may also learn that about the work of John Snow in the investigation of cholera in London in 1854. And this is the application of epidemiological concept to address that issue. You also may learn about the work of Sir William Richard Dawes, who proved that smoking causes cancer. And this work has been published many years ago in the British Medical Journal, in a peer-reviewed journal. And in Cambodia recently, some of you may recall the Roka HIV outbreak. During this event, the epidemiological concept was used to investigate the cause of spread of HIV. And this work was done by, was led by His Excellency Professor Dr. Min Chi-Lun, Professor Satomodata, Pasteur Institute, and a few other partners. Epidemiology is a mandatory discipline in many training programs in health sciences and public health, in addition to biostatistics. So if you learn public health and many other programs, epidemiology is a must learn. You cannot escape, given its benefits and interesting application in this area of health sciences and public health. However, nothing is perfect in this world. And this would also apply to epidemiology. And you will learn more about the success and limit of epidemiology from the lecture delivered by Professor Fontanet shortly. And it is our hope that this seminar will provide you with more insight into and interest in the application of epidemiological concepts in health sciences and public health study and research. And we hope that this would encourage more participants to build their capacity in this useful discipline. There are many ways to support lifelong learning, to respond to the challenges faced by organizations in the time of information technology and information overload. MOOC, MOOC has been used to provide training in many disciplines. In epidemiology training, the UHS and partners supported interested learners in the study of concept and method in epidemiology delivered through MOOC. The first batch of the participants has completed this course, and the second batch will start soon in the future. And I would like to take this opportunity to thank our partners for their support for the UHS students to enroll in this course, and hope that you will continue your support for the next one. I would like to close my remarks by congratulating the 16 successful participants who completed the MOOC in concept and method in epidemiology. And I do hope that the knowledge gained from this course will help them in their study and research. And I wish their seminar as a great success. Thank you. Next, I would like to invite Dr. Didier Fontenille to give a short remark and also introduce our speaker.
Excellency, dear colleagues, faculty members of the University of Health Science, dear colleagues from Institut Pasteur du Cambodge. I think I can also speak in French because I understood that you so let me know if you prefer French than English. No, everyone in English. Dear colleagues from the health sector in Cambodia, and not only from UHS or IBC, and also I'm very happy to see so many students here from pharmacy and medicine and maybe some others, and it is very good. So my first remark is we need you. We need you for epidemiology. We need you for biology. We need you also for science. Please join us. Please come. So we're not only having a degree, but also doing much more later on in epidemiology and growth science. So it is the second top-level conference organized by UHS and IBC at the University of Health Science. And so I'm very happy and also very proud of these opportunities offered by University of Health Science. So thank you very much. And the first, if you remember, the first conference was Sharon Lewin on HIV/AIDS. Sharon Lewin from the Institut at Melbourne University in Australia. I think this is something we can continue into next year, in the future, because it is also good opportunities for sharing ideas and also for getting accurate data and accurate knowledge on some disciplines. And also it clearly demonstrates that there's a very good relationships between University of Health Science in particular, and Institut Pasteur du Cambodge. Institut Pasteur du Cambodge is a Cambodian International Research Center, and so we are hosting students and interns and then engineers, medical doctors, researchers. And the university is also doing research, and we have some research in collaborations already, particularly hepatitis, HIV, and it is the reason why we can work together. We have to work together. And another example, very good example, is the master in infectiology, biology of infectious diseases. Offered by University of Health Science and the French University Paris-Saclay with the help of Pasteur Institut Pasteur in Cambodia and Pasteur in Paris. So it is also a very good example of collaboration, and maybe some of you will be interested in registering in such a master in infectiology this year, in October this year. So Arnaud FONTANET is a very eminent researcher and professor at Institut Pasteur. So he has many titles. So I'm very sure I will forget some. So professor at Institut Pasteur in Paris, professor at the Collège de France, and CNAM is another body of education in France. So Arnaud has the honor to give this conference today related to epidemiology, and as the vice rector mentioned, it is a major great interest for everyone here in this amphitheater. So I want to thank again University of Health Science for hosting this conference, and also thank you very much, Arnaud, for giving us this opportunity to know more. Thank you.
So to continue continue the seminar, I would like to invite all the honored guests to come back to your first seat and invite Professor Arnaud to have your speech, please.
First of all, thank you very much for this invitation. I feel very honored, very pleased to be here. Thank you, Dr. Michimu, for being here. Thank you very much, Professor Saint-Sophie, for this invitation on behalf of the University of Health Science. I would like also to thank Professor Didier and Professor Fontanelle, and all the people who have contributed to this event. Didier Fontenille from Pasteur Institute doesn't need the introduction, and for also organizing the course this week in your institute, where I had the privilege to come and give some lectures. And now I would like to thank those of you who have contributed to make this use of MOOC, Massive Online Open Courses concept and method on epidemiology, to make it available to medical students. I find this is a really very nice initiative. As you understand, about 6 years ago, I have started to make this recording online of lectures in epidemiology. It is delivered every year. About 3,500 students follow this MOOC every year. Not all finish it. For those of you who have followed it, you know that it requires quite some work and some effort. But it is for me very gratifying to know that everywhere in the world, every year, more than 3,000 students start this MOOC, and an important number of them finish it, pass the exam, and this way have been introduced to epidemiology. It's not meant to replace a lecture. I really believe in face-to-face teaching, but I think as an introductory course, and when it can be given, as was done with the help of a number of you, in a way of exchange between the students and experienced epidemiologists that can share their knowledge with the students, it can really potentialize the benefit that you can get from that MOOC. And I'd like to thank here Piravine, Kenere, Patrice, Amber, Steve and Olivier, and particularly Steve and Olivier for their very important investment in making this possible. The lecture of today will address the success and limitations of epidemiology, and what we are going to do for the following 40-45 minutes is an examination of some of the most significant research work, papers published in the area of epidemiology, which have had a real impact in public health. And to do this exercise, I have contacted my colleagues, epidemiologists, and asked each of them, can you tell me one or two papers that you believe are major papers of epidemiology, very strong methodology, and which have changed recommendations, which have led to progresses in the way public health is practiced, and with a real impact in terms of life expectancy, for instance. And here I will review with you a series of maybe 10-15 papers, very simply a one slide paper, but just showing you where the critical knowledge was got from a wide design and wide practice of epidemiology, so that recommendations could be made in public health and life of populations could be improved. And there I'd like to come back to one of the objectives of the group which has helped in making this MOOC available to all of you, is to develop your critical understanding of scientific literature, which goes through what we call critical appraisal of public literature. It is really important as medical students that you learn how to get to the international literature and read the papers and develop your critical judgment of the papers. Don't take all what is written as granted, but look at it with interest, with curiosity, but also with a critical mind, and try to find out, well, this is very important new message that I have learned in this article, but maybe this is missing, maybe it would be useful to continue and do this. And you as medical students, for your continuing education, when you will be out of the Faculty of Medicine, it will be very important that you keep this curious mind and that you go on reading the literature and develop this sense of how much can I get from this, and if I were to repeat this study, what would I do more to improve the knowledge and contribute to the general international knowledge. So it is with this spirit that I have chosen a series of articles which have been critical to the understanding of human health and have really contributed to the impact on life expectancy, for instance. So you all know the link that exists between epidemiology and prevention. You are all familiar with the risk associated with tobacco smoking, too much drinking, and you having a balanced diet, how important it is. You are aware about the importance of screening for cancer, screening for infectious disease like HIV/AIDS, or just simply screening your blood pressure. What you may not know is that these recommendations are based on studies which have enrolled hundreds of thousands of individuals who have been followed for 10 years, 20 years. I mean, these recommendations didn't come out of the mind of experts who were put at the table and say, what should we do for improving health? Of course, they can contribute for ideas, hypotheses, but later on, there were studies with hundreds of thousands of individuals followed dozens of years before those recommendations could be made based on facts. And epidemiology has contributed a lot to that. As you know, epidemiology is the study of the distribution and the determinants of the health events. By distribution, we understand who is sick, when and where. This is descriptive epidemiology, it is a surveillance. And by the study of the determinants of disease, we talk about what we call analytical epidemiology. We study the cause of disease, why some people become sick and not others, what are different between those individuals and why they have different course of disease, for instance. But in epidemiology, we are very concerned about application in public health. We don't do studies just for the pleasure of doing a study. When we do a study, we also want to have a concrete recommendation and impact out of the work we are doing. And that's what is written here, application of results to the control of health problems in the population. Epidemiology is everywhere now in our societies. I mean, you cannot open a newspaper, you cannot listen to the news on TV without hearing about some controversies about, well, what is the effect of pesticides, air pollution, tobacco. Here you have debate about cholesterol. I mean, mobile phones, are they dangerous for health? And all those issues are at the heart of our societies. There are debates. And you, as future medical doctors, and for some of you, I hope, as future epidemiologists, you can contribute to this debate and the knowledge by making the studies which will answer those issues, and I would say in the context of Cambodia. It is important that you do studies that can go beyond the boundaries of the country, but already in Cambodia, there are some specificities in your way of living that would make those studies useful to understand how do they compare with your personal expertise and how should you shape your recommendations to your local context. So I'm going to focus today on the analytical epidemiology, the study of determinants of disease. I'm not going to deal with surveillance, which is a slightly different topic, which has already been addressed, I believe, many times, because as infectious disease specialists and infectious disease epidemiologists, we cover a lot of surveillance. But I'm going to shift here to more the determinants of disease, and we are going to talk about all sorts of disease, a little bit of infectious, but also a lot of chronic disease, cancer, cardiovascular disease. As my understanding is that the country, like many other countries, is now following this epidemiologic transition, where you are moving a little bit away from infectious disease and getting into those chronic disease, cardiovascular, cancer, which for you as medical students are going to be the sort of disease that you will have to deal with as practitioners. But don't forget infectious disease, they can be back, and there were some very good examples which were recently given in this introduction. When we talk about the cause of disease, you have basically on one side your genome and the genetic susceptibility that you may have to some disease. Some people will be more likely or less likely to develop disease depending on their genetic background. And you have all what is around, which we call in epidemiology exposure. And there is now a new term which has been created, which we call exposome, which brings together all sorts of exposure that you can be facing from the conception, including the intra-uterine life. I mean, when you were in the womb of your mother, to death. And what is really important is this combination of your genetic background and the interaction with all the exposures that you will be susceptible to meet during your life, whether you talk about your behaviors. When I say behaviors, it's smoking, alcohol, diet, for instance, doing exercise, or the environment, and the environment can be air pollution, but it can be also infectious disease, which can be carried by mosquitoes. I mean, I'm not saying this because Didier is in the room, and as you know, he's a very famous entomologist. I mean, that slide has been with me for some time. It can also be the drugs that you take. So all that puts together what we call the exposome. All the exposure you can be facing from conception to death. The epidemiological transition is an important concept. Here, I'm taking the example of the United States of America. And here, if you look at this graph on the left, you have the mortality related to infectious disease in the US during the 20th century. So you can see that it declined dramatically, mortality for infectious disease. And that decline, which went down from 800 per 100,000 per year down to 50, so it was divided by 16, took place mostly during the first half of the 20th century. And why is it important if it took place during the first half of the 20th century? It's because at that time, they didn't have yet antibiotics and they didn't have yet vaccines, except for a little bit of the vaccine against smallpox and typhoid fever, but they were not working so well and they were not widely distributed. All those progresses, and you can see how dramatic it is, took place just because of the progress of hygiene. We are talking about access to clean water, we are talking about sewage, we are talking about living in less crowded environment, we are talking about better food, and all that managed to bring down the mortality by infectious disease dramatically in the States, and vaccines and antibiotics took over from the middle of the 20th century to maintain it low. What you can see here is a peak related to Spanish influenza. You know, this major flu pandemic that took place in 1918-19, very about 100 years ago now. And this small increase at the end here is HIV/AIDS, which in the States started to play a significant role towards the end of the 20th century. But here, what is really important to realize is how basic hygiene already managed to deal with infectious disease very well, and then the antibiotics and vaccines took over to maintain all those progresses to the level we know. If you look to the right here, you have this is infectious disease mortality of the different scale, and here you have chronic disease mortality. And here you have the two together, the two combined. What you realize is that during the 20th century in the States, while infectious disease mortality was going down, the chronic disease mortality was staying about at the same level. And here we are talking about cancer, we are talking about cardiovascular disease, and later on neurodegenerative disease. What you realize now is that toward the end of the 20th century, the main cause of mortalities had become cardiovascular and cancer, and were no longer infectious disease. Don't forget infectious disease, they can come back very abruptly. We have seen this with SARS, we have seen it with the threat of avian flu, we have seen this with Ebola, and HIV/AIDS was a major example of an infectious disease that is 50 years old, which by the time of history of humanity is a very short period of time. and can have traumatic consequences. But at the same time, you now have to face the other cause of disease, which are these cancer, cardiovascular disease, and neurodegenerative disease. And for why I go through this introduction is that a country like Cambodia is moving towards its epidemiological transition exactly the same way, and because the way we had to address the cause of disease has changed dramatically. At the time, infectious disease were killing the people. What, as an epidemiologist, you had to do was to find the microbial agent responsible for the infectious disease. In fact, it was work of microbiologists. You have to identify the cause of typhoid fever, salmonella. Tuberculosis, it was Core who discovered the bacillus responsible for tuberculosis. Plague, Yersin for the pestis, Yersinia pestis. So for each disease, you had identification of the agent responsible for the disease, and that was work of microbiologists. When we moved to chronic disease, like cancer and cardiovascular disease, it was no longer one cause for microbiology to discover. All those diseases have multiple causes. And the methods, the techniques to understand what would be the cause of cancer and the cause of those chronic diseases had to be created. And that's how analytical epidemiology was created, because they had to face, during the second half of the 20th century, new diseases which were multifactorial. And how do you investigate those multifactorial diseases is by developing techniques that are taught in epidemiology on how to handle diseases that have multiple causes. So the first disease that epidemiologists have faced in the beginning of what we call the modern epidemiology, so this is the second half of the 20th century, was lung cancer. And what you see on this slide is the tobacco consumption, smoking, rising in England and Wales at the beginning of the 20th century, and 20 years later, the rise in lung cancer. And for the people working in medical doctors working in the UK and elsewhere in the world, they were seeing more and more patients coming with lung cancer. By talking to the patients, they knew that tobacco had something to do, but someone had to formally prove the role of tobacco, and this is what epidemiologists have done. If you wanted to, for sure, say tobacco is a cause of lung cancer, the easiest approach would have been to do a randomized trial. So what you do with a randomized trial, you take a group of people and you randomly assign them either to smoking 1 packet of cigarettes per day, or they smoke but there is no tobacco in the cigarette, this is a placebo, and you follow them for 20 years, and you look at who is developing cancer or not. And you will all agree with me that this kind of study is not possible. You cannot do that, first of all because people don't change behavior like this. They will never accept to start smoking because they have been told by the investigator you should smoke 1 packet per day. This is absurd. And you will all agree with me also that it would not be ethical. So those randomized trials were not possible. And epidemiologists had to find other ways to prove the link between tobacco and lung cancer without doing a randomized trial. So what they did was the first case control study. And that case control study, we owe it to Richard Doll and Austin Bradford Hill, who were 2 very famous English epidemiologists. They were working in London, and during a period of 4 years, or 2 years, sorry, in 20 hospitals of London, they had recruited cases, patients who had lung cancer. There were 709 at the end, and they recruited controls. And those controls were patients hospitalized at the same place, of the same age, same sex, but who did not have a cancer. And they asked cases and controls, how much have you been smoking during the past 20 years? So this is a case control study. You take people who have disease, a control group representative of the same population from which your cases emerged, and you ask them, to what have you been exposed in the past? And in that case, it was tobacco consumption. And the results of the study, so I'm going to show you the figures as they came out from the original papers. Sometimes it's not very explicit, but I felt it was nice that you see the first publication, as it was in the book, and here we are in the British Medical Journal. And what they have shown, to the left you have men, and to the right you have women. And in black you have those who have lung cancer, and in white you have those who didn't have cancer, which was a control group. And as expected, the proportion of heavy smokers, these are people who smoke 2 to 3 packs of cigarettes per day. The proportion of heavy smokers was higher in those with lung cancer compared to those who didn't have lung cancer. So this showed the role of tobacco for the first time in the scientific study. It was statistically significant with the chi-square test, and that was the first study proving the role of tobacco for lung cancer. It was also quantifying it. What I want to alert you is that the controls we are telling you about the general population, in men, only 4% did not smoke at that time. Everybody was smoking in England, every man was smoking in England in the 50s. Only 4% did not smoke among the controls. And if you look at women here, you have the same trend. About 50% of women were not smoking. But just to tell you that some progress has been made, at least in Europe, in smoking, and there's still a lot to do, because you will see throughout my presentation that smoking is doing a dramatic impact on health. But that was the first study documenting it. The next major topic for the epidemiologists has been cardiovascular disease. And here, what triggered the interest of the scientific community for cardiovascular disease was the death of Franklin Roosevelt. Franklin Roosevelt was the president of the United States of America. We are just after the Second World War, and the US are emerging as a superpower for their role during the Second World War. And Franklin Roosevelt, I mean, if you think he's the president of the United States of America, has been going on living with high blood pressure for 10 years, with very little interest from his personal medical doctor, who felt he has high blood pressure, fine, we can't do much about it, nothing really worrisome. It's only in March 1944, at the time they were preparing the landing of the American forces on the French coast of Normandy, that his daughter was really worried, and she said he should be seen by a different doctor, and she brought her father to a naval hospital from the army, where a very young and bright American cardiologist examined him and said, well, he has major hypertension, and he has a beginning of heart insufficiency, something should be done for him. And unfortunately, there were not many drugs for high blood pressure at that time. The diuretics came a bit later on. But they did try at least to stop salt, basic, and some digitalics for the heart. Unfortunately, it was too late, and he died 1 year later from a stroke. And but that, for the American public, triggered something about, well, heart disease are important in our country. Our president died of it despite medical care. And Harry Truman, who succeeded him, decided to launch a national heart study, and one of the biggest cohorts for studying risk factors for cardiovascular disease, which is called the Framingham cohort. Framingham is a city next to Boston in the States, and there they did the first large cohort study. So what do you do when you do a cohort study? You take a group of individuals who are free of disease, and you follow them prospectively. Thank you. You follow them prospectively over time. They are free of disease at baseline. You measure what you think are potential risk factors for the disease, and you measure health events, and in that case, cardiovascular disease. And you look if there is an association between the risk factors that you were suspecting and the development of disease in your group of individuals. So in 1948, they recruited 5,209 men and women in Framingham, and they followed them over time, and the follow-up is still continuing today. And the cohort has grown by including the children of the first generation of patients and the children of children. On this picture, you have 3 generations of the same family participating in the Framingham cohort study. One of the main outcomes of the Framingham cohort study has been the identification of a series of risk factors that you all know and you have all learned in medical school for cardiovascular disease. what you may not know is that what you have learned here came out from the Framingham study. There have been, of course, other studies since, but really that Framingham cohort gave most of the knowledge that we have today regarding cardiovascular disease. And to the left, you have a series of risk factors like high blood pressure, smoking, diabetes, obesity, hypercholesterolemia. And on this graph, you have men and women. You have the risk of developing cardiovascular disease depending on the risk factors that you had at the age of 50. So if you start at the age of 50 here, up to the age of 90, if you didn't have any of the 5 risk factors, your risk of cardiovascular disease is only 5%. If you had at least one, you move up to 36% for men. And if you add more, you can get up to 69% of this graph. When you, as medical doctor, you will see patients, you will ask them about their behaviors, and you will learn about smoking, you will learn about their weight, you will learn about cholesterol and everything. You will use a score, and you will add up numbers, and you will decide, I'm going to treat you aggressively for your hypercholesterolemia, or not so much, because you don't have any other risk factors, so your risk of developing disease is small. But if you see that the risk is high, then you will say, I have to be very, very aggressive with this patient because I need to bring down those risk factors. When you are going to do this, you are going to use a score. That score was created with a Framingham cohort study and has been updated since, but really it was a major advancement in the understanding of cardiovascular disease. So after those first epidemiological studies, and very early, Austin Bradford Hill, still the same from the case control study on lung cancer, developed a list of criteria for causality, a little bit like Core has done for the core postulate in microbiology to say whether a microbe is associated with a disease. There was a series of criteria. I'm just going to comment on a few of them. All these criteria have been criticized since, and people have said, well, that criteria does not apply, whatever. This is normal. This is part of the critical mind that you should have as well. There is one criteria that nobody has denied since, is temporality. Your exposure has to precede the disease to be causal. It's not possible that your exposure takes place after the disease. So causality, or temporality, sorry, has not changed since. The strength of association is important. For those of you who have followed the MOOC, you remember that we estimate relative risk, increase in risk of disease for the exposed compared to non-exposed. This relative risk can be 1.5, 3, 5. The higher it is, the more likely it is causal. It's not a strict rule. There are some well-known causal risk factors for which we know that the increase in risk is small. These were very large studies who made it. But the larger is your relative risk, the more likely it's going to be causal. The consistency is an important criteria. By consistency, we mean if you have one study which identifies the relationship between exposure and disease, this is good. But if somebody else, elsewhere in the world, will make another study and find the same result than you, then you start to believe a little bit in it. And then if there is a third investigator elsewhere repeating the study and finding the same result, then you start to say, well, this is a true causal association. And now it is not one study which is going to change completely the recommendation. It's a repetition of at least 2 or 3 studies with the same result that will be convincing. And finally, there is plausibility, which I put here, which is really important, is that you need to match your epidemiological finding with some biological reasoning. You need to have a mechanism that you can attach to it. If you have an epidemiological finding in the population, but there is no biological mechanism that explain it, it's not good. But I would say this is reciprocal for our colleagues in biology. If they find something, but in humans, they don't find the same phenomenon applied, they should also question their biological findings. It may not apply to humans. So this is something that goes together, and the more we think about causality and science, the more we believe that it is important that in parallel, we have the biology and the epidemiology converging to the same conclusions before we can say it is causal. So there is a graduation in the epidemiological studies in saying whether you get evidence for your recommendation. The weakest study are the ecological correlation, and I'm going to give you an example. Then we have the cross-sectional survey, then the case control studies, then the cohort studies, and then the randomized trial. The biggest evidence comes from a randomized trial. We already discussed it, but it is not always feasible. You cannot randomize people to behaviors. They are not going to change behaviors, and it's not ethical. But sometimes we can do it, and I will give you some examples of it. So if you want to follow all this process from correlation to randomized trial, there is a good example with the observation of the impact of circumcision on the transmission of HIV/AIDS. In the early 90s, Stephen Moses, an American epidemiologist, was looking at the map of HIV in Africa, and he could see the big areas of HIV prevalence, where the eastern part of Africa, a little bit of Central Africa, and Ivory Coast. And he was looking at another map, which is a map of circumcision in Africa, or here, non-circumcision. And here you have the areas of Africa where people are not traditionally circumcised. So he was surprised by this correlation that you see here, this correlation in time and place between the places where HIV was the highest and the places where people were not circumcised. And he started to think, could it be that circumcision protects against HIV transmission? And there are some biological rationale for it. For instance, the foreskin that you remove with the circumcision, the foreskin can be easily traumatized during sexual intercourse, bleeding, and therefore that could facilitate the entry of HIV. Or it may, in the foreskin, be that there are some cells which are good receptors for HIV virus, and if you have the foreskin, it can be easier for HIV to penetrate. So there is some rationale. But ecological correlation, we know, are a weak scientific proof. So there were a series of studies which were performed, case control studies, cohort studies, cross-sectional surveys, which were looking at the association between HIV and circumcision. And what you find here you have what we call the odds ratio, which is a relative risk. If it is 1, there is no association between circumcision and HIV. If it is more than 1, circumcision increases the risk. If it is less than 1, circumcision decreases the risk of HIV transmission. And as you can see here, all studies were pointing to a decrease in risk of being HIV infected if you were circumcised, like if circumcision was protected. But then some people say, okay, maybe it is the biology behind, but it could also be that this is just behavioral, because being circumcised happens because you belong to a certain social group, cultural group, religious group, and maybe those people, they have behaviors that put them less at risk for HIV. So the decrease in HIV infections that you see has not to do with the biology of circumcision, but just at different behaviors that people who are circumcised may have that would protect them against HIV. So the way to solve this debate was to do randomized trial. And this is what has been done by 3 different teams, where they did a randomized trial in South Africa, Kenya, and Uganda. They were recruiting participants in this trial who were men who were not circumcised, and they were excluding them. If you participate in this study, we are going to randomly assign to a group where we are going to circumcise you or not. And we follow you over time, and we will see the incidence of HIV in the 2 groups by randomization. Of course, they were also advised about HIV counseling. You are not doing these experiments and leaving people exposed to the risk of HIV for the sake of your study. When you do a study like this, you, with your study, give counseling, explain how to protect against HIV. Still, some people may not follow your recommendation. And when you look at the results of the trial, this is what happened. There were some people becoming HIV infected despite the counseling. But what was important is that the incidence of HIV was higher in the group that was not circumcised compared to the group circumcised. And in these 3 randomized trials with thousands of individuals enrolled, you had about 50% decrease in HIV transmission in the group which was circumcised, and that demonstrated the efficacy of circumcision in prevention of HIV transmission. It has since been applied by UNAIDS in countries which have high HIV prevalence and where there is a large proportion of men who are not circumcised. So that was the recommendation of UNAIDS following those trials. But you have seen how a correlation study, the first map I showed you, allowed to raise an hypothesis. Then you do a series of studies, case control, cohort studies, that again tells you something is happening in the right direction. But to get the proof, because of the confounding by behaviors, they had to go to a randomized trial. And do 3 trials, 3 studies, not only one, 3 studies, with the same effect, managed to convince people about the efficacy of circumcision for the prevention of HIV. Of course, it goes together with all the modes of prevention. So now I'm going to tell you about some major contributions of epidemiology. I'm going just to give you some examples, not as detailed as what I have just done now. When it comes to the role of tobacco and cancer, and again, please remember and tell your patients not to smoke. I'm not talking about you, you do what you want. But your patients, as physicians, you have to tell them not to smoke. In this cohort of male physicians, which was done by Dole and Hill, the same for the case control study and Richard Pito, they demonstrated, following 34,000 physicians over 50 years, that tobacco was responsible for 15 cancers. And there is just one they missed compared to what the International Agency on Cancer is recommending, where they have identified 16 cancers that are associated with tobacco. I think they didn't see the cancer of nasal cavities, to tell you. But basically, that big cohort study of male physicians smoking identified 15 out of 16 tobacco-related cancer. There was another interesting study about what we call passive smoking. When you smoke, you put yourself at risk. You make this decision, fine. But what is important is that you put also at risk your neighbor. And to prove this, Dimitri Trikopoulos, who is a Greek epidemiologist, had a great idea. In Greece, in the 70s, it was not acceptable for women to smoke. Socially, this was something that was considered not desirable. So, what Dimitri Trikopoulos thought is, if women develop complication of tobacco, it is not because they smoke, this is forbidden by society, but it is because of the smoking of their husband. And therefore, he did a case control study where he recruited women with lung cancer and women without lung cancer, and he compared the exposure to the husband smoking. And what he found is that so this is taken from a movie, you may not know it, but it's called Zorba the Greek. And it's Anthony Quinn who is playing this movie, and that's why I put him for this example. If the husband is smoking, 1 packet per day, the wife has 2.5 increase in risk of developing a lung cancer. If it is 2 packets per day, it's 3.4 increase in lung cancer compared to a husband who doesn't smoke. That study itself was important because it was showing the impact of tobacco smoking, well, passive smoking, and what we call passive smoking, but also it gave to the lawyers the scientific reasoning for forbidding smoking in public places. And at the time you start to forbid smoking in public places, it becomes much more difficult for smokers, to continue their habit because they are stigmatized. They are told, if you want to smoke, you go in that closed room, where you have a lot of smoke or smoke. Nobody wants to go in that room, And the impact of forbidding smoking in public places has been tremendous on just the habit of smoking, because then people who were smoking, they were not the trendy one. In the 50s, when you were smoking, it's in France, Alain Delon, this actor was smoking and good looking, whatever. Well, the day you stigmatize smoking in public places, people no longer want to smoke, and smoking has gone down, and this is why this study has been particularly important. Another very important study is the nurse health study, which was carried out in the States. They followed a cohort of nurses, female nurses, that were recruited in 1976. And here, if you add up the different inclusion, you have more than 250,000 nurses who have been followed for 50 years. And they have been followed to identify different risk factors. Among the risk factors that have been studied by this group, there were the role of oral contraception in cardiovascular disease and in cancer, and the role of diet. And this group has contributed a lot to all what we know today about the risk of cancer or cardiovascular disease associated with diet. But here, we talk about 250,000 women followed for 40 years. I mean, can you see the size of the study? 93% follow-up rate. I mean, they managed to keep them in study because they had jobs and they could trace them easily. 93% follow-up rate for this study. So, we are talking about more than 3,000 publications, but just one summary. 50% of cancer could be avoided in women with the following recommendations. I'll let you read those recommendations. You already know them. Hopefully you have incorporated that in your daily life. There is maybe one which now people would look suspiciously is taking multivitamins daily, because here, randomized trial later on with multivitamins didn't find the effect of the cohort. But I will talk a little bit about that later on. But for the rest, don't smoke, do exercise, avoid weight increase, have a balanced diet. All that is very important. That study, for instance, the nurse health cohort study has been used to confirm hypotheses which had been raised by another ecological correlation study. Here, what you see is the annual rate of colon cancer in women by daily consumption of meat. This is calculated at the level of the country. And on the top right, you have New Zealand here. And here you have United States, Canada, and if you go down, for instance, you have Japan. And you see that the more people eat meat, the more likely they will have a colon cancer. But here again, it's an ecological correlation calculated at the level of the population. You need the individual study to show, not at the level of the country, but at the level of the individual, that red meat could, for instance, increase colon cancer. And this is what they did in the nurse health study. The quality of the slide is not very good. It's an original paper, but I'm just going to tell you the finding. Compared to a woman who eats meat, red meat, less than once per month, if you eat more than one per month, once per week, up to more than one per day, your increase in risk of colon cancer moves from 1 to 1.39, 1.50, 1.85, 2.49 if you eat meat every day. And here you see you have this dose dependence, which is kind of suggestive that your study is of good quality, which show that if you eat too much red meat, you increase your risk of colon cancer. Here again, ecological correlation to raise hypothesis. You go back to the nurse health study, 250,000 women followed 40 years, 147 colon cancer, and you can demonstrate whether there is an association. Now, in infectious disease, two studies which have had a real, very important impact. You are all familiar with hepatitis B infection. And the first study that demonstrated the link between hepatitis B virus and, why do I say lung cancer, and liver cancer, sorry. So, hepatitis B virus, liver cancer, I'm glad that you're awake. This study came from Taiwan, a country which had a very high prevalence of hepatitis B. 22,000 civil servants, and because they are civil servants, you can follow them easily. You know, when you do a cohort, you take a group that you know you can find with time. That were followed for 5 years, and they identified 40 liver cancer, 17 cirrhosis, and only 1 and 2 in the group which was HBs antigen negative. The increase in risk of liver cancer if you had hepatitis B antigen was more than 200 times. So this is the first study that demonstrated the link between the hepatitis B virus and liver cancer. And that has been the recommendation. Taiwan, as you may know, has been one of the first countries which introduced the immunization for hepatitis B. And they saw the decline in first HBV prevalence and now lung cancer. They were also the first one to demonstrate it. Another study about papillomavirus and cervical cancer. You know human papillomavirus, HPV, and the Not sure it works, but that's... So, papillomavirus and cervical cancer. Thank you. So here they did a case control study, 759 women with cervical cancer in Latin America, 2 controls per case, matched on age and hospital, and they compare the prevalence of human papillomavirus between those women who were with cervical cancer and those women who did not have, and they saw a higher prevalence of papillomavirus among those who had cervical cancer. I'm going to skip a few slides for the sake of time, because I'm afraid that I'm going to be a little bit late otherwise. There were studies that showed, for instance, for the babies, that you have to put them on the back rather than in ventral position to prevent what we call the sudden infant death syndrome. And that was a very easy study to perform, case control study. In the late 80s, there were many babies, healthy, mostly boys, 2 to 4 months of age, and the mothers or fathers were finding them dead in the morning, and that was really tragic. And by a case control study, very simple, on which position do you put your baby to sleep in the evening? There were 19 case control studies, and very quickly identified that there was a high rate of sudden infant death syndrome if the babies were put on ventral position. And the recommendation of putting them, as you see on the back, came out of those studies and reduced by 70% the sudden infant death syndrome. So very easy case control study which has this result. For a few words about HIV prevention, I think that it is important that I refer to it. 2 randomized trials which I think are really important. One where they randomly decide to treat immediately people who at that time, we are in 2011, didn't have an indication for treatment. They had CD4 between 350 and 550. But they decide, we treat immediately or we delay your treatment. And what they observed is that not only those that were treated immediately were doing better clinically, but they were not transmitting HIV to their partner. They started with 1,763 what they call discordant couple, one infected, not the other one not infected, randomly assigned. And not only you improve the clinical state of the individuals if you treat early, but you prevent transmission. There were 28 HIV transmission, 27 out of 28 in the delayed arm. So that recommended that not only you treat early for the clinical benefit of the patient, but also stop transmission. This was a trial coordinated by Marion Cohen, and the trial was stopped by the Data Safety and Monitoring Board because they could see early in the trial that the effect was dramatic. Another important study is the HIV transmission prevention for men who have sex with men, where they realized that if you take just before and after sexual intercourse TNF plus FTC, you prevent the risk of becoming HIV infected. Randomized trial, placebo for the other group. Again, HIV infections happening in the placebo group, and the Data Safety and Monitoring Board just stopping the trial. I'm a bit concerned about time. I believe that I have to shorten a little bit. So I'm going to be a little bit quick on this part about the depth of epidemiology, the limitations of epidemiology. You will believe that there are no limitations of epidemiology, but it would take me a bit too much time to proceed with the slides which follow. I will just alert you on one limitations of epidemiological studies that is important, and I will skip some of the slides. The limitation that I want to raise here came from the criticism of Peter Skrabanek at the time when you had these very big cohort studies going on all over the world, and people were crossing all the items they had put in their questionnaires with disease without any biological reasoning. They were just doing what we call a fishing expedition. You have a questionnaire, you ask 200 questions about diet, and then you have 5 or 6 diseases in your cohort study, and you cross everything, and you look at what is statistically significant. And for those of you who have followed the book in epidemiology or are aware of epidemiological methods, you know that by chance, if you have no association, 1 out of 20 tests will be statistically significant. This is random fluctuations. And if you do thousands of tests because you cross everything, you will get positive results, which are just random fluctuations. This is one of the limitations of epidemiology. And there was a time where the investigators were just doing this without thinking too much, finding association. Peter Spabanek was laughing about an association about consumption of tomatoes and cervical cancer, for instance, that came out in the scientific journals. The scientific journals, they will publish what is significant, and if it is not significant, they reject. And all this, you know, I mean, we have been victim of this in the field of biomedical research and epidemiology. And Peter Spabanek was calling the epidemiologists the risk factorologists, because we were all publishing about risk factors without any biological reasoning. I will go straight to the last slide. Last week, in Nature, which is a very important journal, there is a group of epidemiologists and statisticians, including Sander Greenland, which is one of the top epidemiologists, who say we should remove the p-value threshold of 0.05. There is no longer a concept of statistical significance. Please read this article, it is important. What it says is just publish your p-value, whatever result is, and leave it to the reader to interpret what the p-value is. The p-value is when you have no association, the probability of observing a difference as large as the one that you have observed just because of random fluctuations. So if your result is, I have a p-value of 0.20, publish it. And the reader knows that if there was no association, there was a 20% chance of observing a difference as large as the one you have observed just because of random fluctuations. That is one element of judgment that you put together with all the other evidence in the paper. But no longer take a threshold of 0.5%. This is the recommendation, and this is a very important one. And now to conclude, I will finish with one slide about the air pollution and mortality. I think it is important that you are aware that I go back to the nurse health study. You remember 250,000 nurses which have been followed over time in the US, and they have been crossing the data of those cohort of nurses followed 50 years with the measurement of fine particles at a scale of 6 kilometers square, so very fine scale, all over the US for 8 years. And you have a very important relationship between here the mortality, all-cause mortality, and the concentration of fine particles, 2.5, as measured over the United States in that cohort of nurses, adjusted for all the risk factors that they have in the study. So they take into account some confounding by socioeconomic status, diet, exercise, smoking, whatever you want. A clear relationship between here pollution, air pollution, fine particles, and all-cause mortality. And I think it is an important message just because air pollution is something that we find now everywhere in the world, and it's an important impact. And here, I just would like to thank the colleagues who helped me in preparing this presentation by sending me some of the articles that I have shown you, and I would like to thank all of you for your attention.
Thank you a lot for Sir Arnaud FONTANET. Now we come to the Q&A question. Please, our team, if anyone has a question, please raise your hand. If you have any question, please raise your hand.
Don't be intimidated. The first one is maybe the difficult one, and then after it becomes easy.
Yeah, we understand that now it is nearly noon, but if you have questions, please raise your hand. Please identify yourself first before question.
I am year 6 medical student. My name is Yerbak, and
started to go down,
Right.
and then the chronic disease remained the same. Yeah.
I don't really see a correlation that it's a shift. It's just that the infectious disease fall, but the chronic disease just stays the same.
Exactly.
So when you hear the term transition, I thought it transitioned from infectious disease to chronic disease. So
What it means basically, as you can see on the slide, is that over 100 years, you move from a situation where infectious disease were the main cause of infectious disease. If you take this one where you have all causes, at the beginning of the 20th century, infectious disease and chronic disease were about the same. They were 50% of the mortality each. By the end of the 20th century, the ratio has become 95 to 5. This is what we call epidemiological transmission. So you move from a 50-50 person cause of mortality to 95 to 5, where really the chronic disease become predominant. It's not that they have crossed, chronic disease remains stable, the other one decline.
So if you have any more questions, please raise your hand. You think you go to your position. No? Okay. So thank you, Professor Arnaud FONTANET, for your presentation. Please come back to the anything to add?
Sorry?
Do you have anything to add?
If you have questions, just write to me, arnaud.fontanet@pasteur.fr.
Thank you. I just heard the information from the organizing committee that his presentation will be online on our UHS page. So please take the presentation. So thank you, Professor. You can come back to your seat. Thank you. So now it's time for the mock student certificate or achievement presentation ceremony for our 15 mock students who have successfully graduated for the first batch. So now I would like to ask Dr. Olivier Sergeral, ANRS representative, to hand out the certificate to the graduate, and I will ask the graduate one by one. Please come to the stage. First, I would like to invite Mr. Chia Seng Ho, please. Ngân Ratana Romania.
So would you please move it? Please move it. Thank you. Okay, please.
Bi Đức Đá. Thank you a lot, Dr. Olivier Sergeral. You can come back to your seat. And now I would like to invite Professeur Didier Fontenille, directeur de l'Institut Pasteur du Cambodge, pour donner le certificat aux étudiants. So please, San Yunan. Jan Freifik, Kat Frenek, control. Rương Sọc Thọ Tuấn. Dulu Maria. Now I'd like to ask Professor Min Chi-woon, advisor to the Ministry of Health, please hand out the certificate. Thank you. I would like to invite Bui Heng. Bui Heng. Heng Childhood. Toma Kupung Panya. Hoi Chun. Thank you, Professor. Now I would like to invite Professor Arnaud FONTANET to hand out the certificate. The last one. Hai Chun Lee, from Jin Hai Chun Lee. Thì nó có phần trên Lao Ly Công Hến. Trong một đời hai trong cái này cứ từ thu ba lịch với lịch đi mùi trong khai là lịch đi cứ chú trong ná là phần chớn. Ở nhà lên muối hay tay cứ lên muối là hốt được 4 giây là. He always the best performance student out of the year. Thank you a lot. So we come to the end, but before leaving, I would like everyone, all my guests and the students had to get a picture together outside in front of the room, please. So much for coming to me back. I would like to invite all our guests, participants, and students to come to in front of the room and have family picture. Thank you a lot.